Hello physios, I welcome you all to our channel Physio Vidyapeeth. So we are back with our next lecture on shoulder complex biomechanics, and here we are going to start the most important part of it, which is glenohumeral joint. Okay, so glenohumeral joint, it is the main part of the shoulder complex, and it is the joint which is formed between two bones, that is humerus, this one, and scapula. Okay, humerus and scapula. So these two bones form the glenohumeral joint. So these are the bones, both are of my left side. Okay, of left side, not actually my, of the left side of body. Okay, so here the articulation occur between the glenoid fossa of the scapula bone and the head of humerus. So you can write that it is a joint between humerus and scapula, and from humerus it is the head of humerus which is taking part in articulation, while from scapula it is the glenoid fossa which is taking part in the articulation. So it is the joint between humerus and scapula. Now let us study that what type of joint it is. It is a ball and socket type of joint. So you can see that this is the head of humerus, and it is more or less spherical. So we refer this as ball, and the glenoid fossa of the scapula is referred to be the socket. So we call it as a ball and socket type of joint. Okay, ball and socket type of joint. Now the next heading, it is the degree of freedom. Since it is a ball and socket type of joint, it is a triaxial joint. Okay, it is a triaxial joint. Okay, it is a triaxial joint which have 3 rotatory and 3 translatory motions. So till now what we have studied, what is glenohumeral joint? Joint formed between scapula and humerus is called glenohumeral joint. From scapula it is the glenoid cavity taking part in joint formation, and from humerus it is head of humerus which is taking part in joint formation. Type, definitely you know, it is a ball and socket type of joint, and degree of freedom, it is a triaxial joint. So 3 rotatory and 3 translatory motions are present, which we will discuss later. Okay, Now the most important part of this lecture is the articular surface. Okay, so articular surfaces can be divided into proximal articular surface and distal articular surface. So first of all, the proximal articular surface. The proximal articular surface is scapula. It is the scapula, and from scapula it is the glenoid fossa which is taking part in the joint formation. So how can you describe this glenoid fossa? So the proximal articular surface is scapula. Glenoid fossa which is present on the lateral side. Okay, so this is the exact position. Present on the lateral side of the bone is taking part in joint formation, or is the main articular surface, and this articular surface is a shallow concavity. Okay, it is a shallow concavity. Okay, which will articulate with the head of femur, head of humerus. Okay, which will articulate with the head of humerus, that is the distal articular surface. Now you need to understand the position of scapula. So under the position we have already studied the resting position. So what was the resting position of scapula? So if this is the vertebral column, it is 5 cm away from vertebral column, extend from 2nd to 7th vertebra. First point. Next point is it is 5 to 10 degree upward rotated, then 10 to 20 degree anterior tipping, and 30 to 45 degree internally rotate. So in under the position you need to write about the resting position. Okay, resting position was it is present 5 centimeter away from vertebral column, extend from second to 7 vertebra, that is the thoracic vertebra definitely, and next is 5 to 10 degree upward rotated, then 10 to 20 degree anterior tipping, and then 30 to 45 degree internally rotated. Okay, so this is the position of scapula. Now apart from this, you need to understand that position of scapula depend upon some factors. So position of scapula first of all depend upon resting position of scapula. Secondly, it depend upon the position of sternoclavicular and acromioclavicular joint. Why? Because in our previous lecture I said one line that sternoclavicular, acromioclavicular joint and the scapula behave like a closed kinematic chain. So whenever there will be change in the position of sternoclavicular or acromioclavicular joint, definitely there will be change in the position of scapula. So these are the points that you need to understand, that the position depend upon resting position. Next is sternoclavicular and acromioclavicular joint position. Also the glenoid fossa itself can be either anteverted or retroverted, that is there can be some degrees of anteversion or retroversion at glenoid fossa, that is glenoid fossa anteversion and glenoid fossa retroversion, where anteversion range up to 10 degree and retroversion up to 6 to 10 degree. Okay, so which are, we can say, more or less related with the different books. Okay, so now under the proximal articular surface, you have studied that proximal articular surface is scapula. Which part of it is articulating? Glenoid fossa. Either it is concave or convex. Definitely it is the concave part, that is a shallow concavity which articulate with the head of humerus. Next point is the position depend upon various factors, that is first one is resting position, second one is position of sternoclavicular and acromioclavicular joint because it act like a closed kinematic chain, and third point is that the position of glenoid fossa itself is also variable, that is either it is slightly anteverted or retroverted. Another important thing regarding the proximal articular surface is that this is the glenoid fossa. I will draw it here as it is. Okay, so it is definitely like this. You can see that this vertical articulation is greater as compared to this horizontal articulation, which I wanted to tell. Okay, so next is the distal articular surface. Okay, so the distal articular surface is our humerus. So we will write here the distal articular surface is humerus, and from humerus definitely it is head of humerus which is taking part in articulation. And you can tell that what is the shape of this head of humerus. The shape is 1/3 or 1/2 of sphere. Okay, 1/3 or 1/2 of a sphere. Now regarding the position of proximal articular surface, we studied about resting position. Okay, then position of sternoclavicular and acromioclavicular joint, and also about the anteversion or retroversion of the glenoid fossa. And here also definitely we will study something that is two important angles. So first is angle of inclination, second is angle of torsion. Now let me make humerus here. Okay, so this is left sided humerus that I have drawn, Now, angle of inclination is the angle which is formed between two lines. So this is the first line, which is the longitudinal axis of bone, and this one is second line, which is the line passing from the head and neck of humerus. Okay, so this angle is called angle of inclination, and its value is around 130 to 150 degree. And in which plane it is present? It is present in the frontal plane or the coronal plane. Frontal plane or the coronal plane angle. So somebody can ask you that what is angle of inclination? First question. And it is formed between which two lines? That is longitudinal axis of humerus and the line passing through the head and neck. So this is humerus, this one is longitudinal axis, and the line passing from the head and neck is like this, and this angle is called angle of inclination. And next question will be, in which plane this angle lies? Okay, it is in the frontal plane or coronal plane. Next is the angle of torsion. See, when you will see the humerus bone from the top view, you will see that head of humerus is slightly posterior with respect to these two condyles, that is medial and lateral condyle of humerus. So when I am looking it from here, I can see that the head of humerus is slightly toward me, okay, rotated backward. This angle is called angle of torsion. So how can we explain this angle? So let me say that there is a line which is passing through both the condyles of the humerus, and I move that line upward and see that head of humerus is slightly backward as compared to that line. So angle of torsion is the angle between the line passing from the medial and lateral epicondyle of humerus. Okay, so this is the line. So when I will uptake this line, I will see that the humerus head is slightly backward. So angle will be just like this, which is around 30 degree, and this angle is called 30 degree torsion or 30 degree retroversion. Okay, did you understand? So it is just like this. Okay, so the head of humerus is slightly retroverted. Now the main question that arises is that what was the need that our head of humerus is retroverted? Let me explain. This was the scapula. Okay, what was its resting position? In the resting position there was one component, that is 30 to 45 degree internal rotation. 30 to 45 degree internal rotation. Now, which I have written here, 30 to 45 degree internal rotation. So if this scapula is slightly internally rotated, and if this head of humerus was at neutral position, there was very less articulation. So to be congruent, the retroversion is there. So the retroversion of the head of the humerus help to increase the congruency. Okay, it helps to increase the congruency of the articular surface. Also, due to more retroversion, it is possible to get better lateral rotation, which you have studied in goniometry. The lateral rotation is very high. Okay, that is 10 to 15 degree more as compared to medial rotation. Okay, why? So you can be asked like this, that why lateral rotation is more in the shoulder joint? Because the head of humerus is already somewhat retroverted. So during the lateral rotation it moves more anteriorly, which give more range of lateral rotation. So we can write, due to this retroversion, the lateral rotation is greater as compared to medial rotation. Okay, and so this is whole about the distal articular surface. Important point are angle of inclination, angle of torsion. Angle of inclination is the angle between longitudinal axis and the line passing from head and neck, and this angle is called angle of inclination. While angle of torsion is the angle formed between the line passing through the condyles of the humerus and the head of humerus. It is slightly retroverted, that is 30-degree retroverted. After studying about the articular surface, we are moving to the next important structure, which is the glenoid labrum. Okay, so it is the structure, that is accessory structure, or we can say it is a cartilaginous structure present around the glenoid fossa. So this is the glenoid fossa, and here, just like this, the glenoid labrum is attached. Okay, it is attached at the periphery of the glenoid fossa to increase its articular surface. So what are some functions of glenoid labrum? It increases the congruency by 50%. 50% congruency is increased. Next important function is it prevents the bony contact between head of humerus and glenoid labrum. So I will write it as it prevents bony contact. So if it prevents the bony contact, definitely it will reduce the friction between the articular surface. Okay, because it is glenoid labrum is smooth. Okay, so it help the, we can say, head of humerus to glide and slide properly. Okay, so reduce friction. Next important function is that it prevent unnecessary translations of the head of humerus. Okay, so normally there are 3 rotatory and 3 translatory motions, but here the glenoid labrum prevent the unnecessary translation. Okay, so it prevent the unnecessary translation. Okay, unnecessary translation of head of humerus. Next important point, okay, it help to, we can say, help to dissipate the force. Let me explain it with an example. I am pushing this wall and force is coming, we can say, directed toward my glenohumeral joint, and that is dissipated like this, dissipated by the glenoid labrum. Okay, so force dissipation. Okay, force dissipation is another important function. So what are the functions? 50% congruency is increased, prevent the bony contact, reduce friction, prevent unnecessary translation, force dissipation, and last point is that it provide attachment to long head of bicep brachii and some ligaments. Okay, and some ligaments. Okay, so these are the functions of glenoid labrum. Increase congruency, prevent bony contact, reduce the friction, help in force dissipation, provide attachment, and prevent unnecessary translations. Okay, so there are total 6 functions of glenoid labrum. So what we have studied till now, we have studied about what is glenohumeral joint, its type, its degree of freedom, which we will discuss later, and next are the articular surface. The 2 angles are very important along with their values, and we have studied the glenoid labrum. Now we are moving toward ligament and capsules of glenohumeral joint. We are going to study about capsule and ligaments of glenohumeral joint. So first of all, the capsule. So this is humerus and this one is scapula. Okay, the capsule of the glenohumeral joint will cover it from all the directions. Okay, so let me explain you from the bones. Okay, so this is glenohumeral joint. It will cover it from all the directions, like my hand is covering it. Okay, so I will draw it like this. Okay, so it is the glenohumeral capsule, but some peculiarities of this capsule are, this is large. Okay, how large? It is that large that it can accommodate 2 times head of humerus. Okay, so it is loose and large such so that it can accommodate two heads of humerus inside it. So it is large, loose and weak. Okay, it is very weak, and this weakness is maximum in anterior and inferior part. Okay, so anterior and inferior part are weakest, while this superior part is more or less taut. Okay, so till now what we have studied, that the capsule of glenohumeral joint will cover it from all the direction. It is large. How large? That it is double than the size of head of humerus. It is loose and weak. Next point, this capsule will be taut in which position? It is the lateral rotation plus abduction, which is the close pack position of the joint. In which position? Abduction and lateral rotation. Which position? Abduction and lateral rotation. Okay, so as it is a weak capsule, so it do not, we can say, provide much stability. So definitely this will be reinforced by the ligaments, which we will study in few minutes. Okay, so under capsule, what are the point? That it cover the whole joint. It is large, loose, weak and the close pack position. Now next point, why this is loose, or this looseness is either a benefit for us, okay, or we can say a weak point for us. Since the capsule is very loose, it permit various or high degree of range of motion. Okay, so shoulder joint is very mobile joint. Now we have 6 movements: flexion, extension, abduction, adduction, lateral rotation and medial rotation. So as the capsule is loose, so it permit all these motions, and this thing is further utilized in mobilization. Okay, as you will study in exercise therapy. So at particularly in the shoulder joint, it is, we can say, possible to get 2.5 centimeter of distraction. Okay, distraction, that is the head of humerus can translate away from the glenoid fossa. How much? 2.5 centimeter by the mobilization. Okay, by mobilization, which is, we can say, further important. Why? Because mobilization is used to treat various conditions in the shoulder joint. Okay, so it is, we can say, utilized as a good thing that we can mobilize it easily. Why? Because the capsule is loose, but this looseness can also become hazardous for us. Why? Because as it is loose in anterior and inferior direction, these lead to dislocation in this direction. Dislocation. Okay, so in which direction the dislocation is common? Anterior and inferior direction. Okay, so this is whole about the capsule. So let me recap. First point, it covers the glenohumeral joint in all directions. Second, it is loose. How much loose? That it can accommodate 2.2 head of humerus. It is large. It is weak. It is weak in which direction? Which direction? Anterior and inferior direction. And either it is good or bad for us to have a loose shoulder capsule. Yes, it can be benefit for us. Also, we can say it can be hazardous for us. Why? Because in mobilization we can get good amount of distraction, so it is, we can say, beneficial for us. But if there is any kind of dislocation, such as in anterior and inferior direction, that is problematic for us. And now we will move toward the ligaments of the glenohumeral joint. Okay, so under the ligaments are grouped under two categories. The first category is capsular ligament and the second category is the extracapsular ligament. Under the capsular ligament, the name of ligament is very easy to remember, as it is the name of joint, that is glenohumeral ligament. And this glenohumeral ligament have three parts: 1, 2 and 3. That is superior glenohumeral ligament, middle glenohumeral ligament and inferior glenohumeral ligament. Okay, inferior glenohumeral ligament. Okay, so now let me make a diagram for you. Okay, here. this is humerus, and this is scapula. Now, this whole is glenohumeral ligament which I am drawing from here to here. But the part which is present at superior part, this thing is called the superior glenohumeral ligament. Okay, it is the superior glenohumeral ligament. And from where to where it extends? It extends from the superior part of the glenoid labrum to the upper part of neck of humerus. Second is the middle part. Okay, this middle part, this arise from the anterior part of the glenoid labrum and extend up to the anterior or the middle part of neck of humerus. And last is this inferior glenohumeral ligament, which extend from the inferior part of the glenoid labrum up to the lower part of the neck of humerus. Okay, so the origin, or we can say extent where the ligament is present, is very easy to remember. All of them will start from glenoid labrum and end at the neck of the humerus, where superior part is moving from superior to upper, middle part is moving from middle to upper and middle to anterior part, and inferior part is moving from inferior to the lower part of neck of humerus. Okay, so this is the, we can say, origin. Now, this inferior glenohumeral ligament is also called as inferior glenohumeral ligament complex, that is IGHLC. Why it is called a complex? This word C is added. Why? Because this ligament, that is the inferior glenohumeral ligament itself, have three parts. First is anterior, second is posterior, and third is inferior part. So this is anterior part which you are we can say watching, and exact behind it there will be posterior part, and third part is the inferior part which I have drawn like this, and this inferior part is also called axillary pouch. Okay, axillary pouch or axillary recess. Okay, so it is having three parts, that is anterior part, okay, posterior part and inferior part. Okay, anterior, inferior and posterior part. Now till now you have studied about the glenohumeral ligament. It is superior, middle, inferior. Superior move from superior part of glenoid labrum to upper part of neck of humerus. Middle move from anterior part of the glenoid labrum to the middle part of neck of humerus, and third one, that is the inferior one, move from lower part of the glenoid labrum, that is inferior part, to the lower part of neck of humerus. And this thing is that is the inferior glenohumeral ligament, also called inferior glenohumeral ligament complex, have three part: anterior, posterior and inferior. Okay, and inferior is called axillary pouch. Now let me explain you the functions of these ligaments. So from the capsule you came to know that the joint is unstable, or we can say weak, in anterior and inferior direction. So definitely the function of this ligament will be to provide stability in anterior and inferior direction. So the function of superior glenohumeral ligament is anterior and inferior stability when the arm is in neutral position. Okay, so I will write here neutral. Okay, now so this will superior glenohumeral ligament, as I am standing now, so my superior glenohumeral ligament is taut, which is preventing anterior and inferior translation, okay, in the neutral position. But when we started doing abduction, that is at 60 degree, anterior and inferior stability is given by middle glenohumeral ligament. So when I reached up to here, that is around 60 degree, the anterior and inferior stability is given by middle glenohumeral ligament, while inferior glenohumeral ligament complex. Now let me make you understand it very easily. First part, that is superior part, will give you anterior and inferior stability. In which position? Neutral position. Second part, that is middle glenohumeral ligament, will give you again the anterior and inferior stability. But in which position? It is the 60 degree abduction. 60-degree abduction. I will write here 60-degree abduction. Now, inferior glenohumeral ligament. Inferior glenohumeral ligament will give you anterior and inferior stability. Anterior and inferior stability. Anterior and inferior stability. In which position? 45-degree abduction, 45-degree abduction and 45-degree abduction. Also, there will be some rotatory motion. When there is 45-degree abduction and lateral rotation, you can feel that there is a stretch on anterior part. Okay, so it will be the anterior part which is giving the stability. And if we are doing 45-degree abduction and medial rotation, there is a stretch on posterior part, so it will be the posterior part which will be giving stability. And in the 45-degree abduction alone, the axillary pouch or the inferior part of glenohumeral ligament will give you stability. Also, you can write it as rotation. Okay, any rotation. And in this middle glenohumeral ligament, here at 60-degree abduction, it give more inferior stability as compared to anterior stability. This is what I wanted you to understand. Okay, so under the capsular ligament, there is only one ligament, that is glenohumeral ligament. Superior, middle, inferior. Which one? Superior, middle and inferior. Superior is moving from superior part, middle is from middle part, inferior is from inferior part. And where they are finishing? They are finishing at the neck of humerus. Okay, all of them will give you more or less anterior and inferior stability. This one in the neutral position, this one in 60-degree position, and remember, it will give more inferior stability. And last one at 45-degree. If it is with lateral rotation, then anterior part, medial rotation with the posterior part. So I will write here MR. Okay, medial rotation. Sorry, medial rotation. It is posterior part, and inferior part will give the stability in 45-degree or any rotational movement. Okay, so this is about inferior glenohumeral ligament complex or the whole glenohumeral ligament. Another important thing under the glenohumeral ligament is the rotator interval capsule, also called rotator interval capsule opening, and also called the foramen of wheat breast. Okay, so what is this? This is a small opening. Okay, let me make you understand it diagrammatically. So it is a small opening which is present between the supraspinatus and subscapularis tendon. Okay, so let me make it with black color. So this is the supraspinatus muscle tendon, this is subscapularis muscle, and this hole or the small opening is called the foramen of wheat breast or rotator interval capsule. You will get a question that what are the components of this opening. So okay, so it include superior part of glenohumeral capsule, superior part of glenohumeral ligament and coracohumeral ligament. Okay, coracohumeral ligament. So what is rotator interval capsule? It is a small opening in the glenohumeral joint present between the supraspinatus and subscapularis. Supraspinatus is present upward and subscapularis is present below, and this opening is also called foramen of wheat breast. And also the components or the contents of this opening are superior part of glenohumeral capsule, superior part of glenohumeral ligament along with the coracohumeral ligament. Okay, so with this we are completing the glenohumeral ligament part, and now we are moving toward the extracapsular ligaments. Okay, so let me just erase this. Extracapsular ligaments. Okay, so they are very easy. Extracapsular ligament are two. First one is the coracohumeral ligament. Second one is the transverse humeral ligament. Okay, so again let us make a diagram. Okay, now coracohumeral ligament, as the name suggests, that it will start from the coracoid process of scapula, and end at the humerus, and at humerus it is, we can say, attached to two parts, from here to here and here. This one is at the greater tubercle, this one is at lesser tubercle, and at the greater tubercle it is present with supraspinatus, and at lesser tubercle it is present with subscapularis. Okay, so the coracohumeral ligament extend from the coracoid process, and it is present superior to the superior part of glenohumeral ligament. So it is present just above this ligament, extend from coracoid to the 2 points, that is greater tubercle and lesser tubercle. At greater tubercle it is present with the supraspinatus, and at lesser tubercle it is present with the subscapularis muscle. Okay, so and between them there is the long head of bicep brachii tendon. Okay, now this transverse humeral ligament, it is present between the greater tubercle and lesser tubercle like this. Okay, that is, it connect the humerus, that is the greater tubercle, with the lesser tubercle, and this is whole about the extracapsular ligament. And the function of coracohumeral ligament is to provide anterior and inferior stability. Also it will give us lateral rotatory stability in adduction position, that is, when there is adduction it will give resistance to the lateral rotation. So it will give anterior and inferior stability, also lateral rotation stability in adduction. And the function of transverse humeral ligament is that it maintain the integrity of the long head of bicep brachii tendon within the intertubercular sulcus, so that it do not get slip outside or move, we can say, away from its place. Okay, so with this we are completing the lecture, and we are done with the capsules and ligament of glenohumeral joint. Okay, so capsule, it is large, loose, weak, and in which direction it is weak? Antero-inferior. It is loose. Is there any advantage? Yes, there is advantage, that it gives very high mobility. It is loose. Is there some disadvantage? Yes, anterior and inferior dislocation is very common. How much centimeter of distraction can you get? 2.5 centimeter. Capsular ligament and extracapsular. Capsular ligament is one, that is glenohumeral, superior, middle, inferior. All of them are starting at glenoid labrum, ending at the neck of humerus. Superior part, middle part, inferior part, no matter, they will give you anterior and inferior stability. But superior part in the neutral position, middle part in the 60-degree abduction position, and here it give more inferior stability. Inferior glenohumeral ligament is also called inferior glenohumeral ligament complex. Anterior, posterior and axillary recess that I have drawn. Anterior and back it is posterior, and like this is the axillary recess. Okay, so they will give the anterior inferior stability in which position? In the 45-degree abduction plus rotation. If it is lateral rotation, anterior part will be taut. If it is medial rotation, posterior part will be taut. And last are the extracapsular ligament, that is coracohumeral, from coracoid process to greater tubercle and lesser tubercle, and they will give anterior and inferior stability, also lateral rotatory stability in adduction position. And last is transverse humeral ligament, will connect greater tubercle to the lesser tubercle and prevent the, or we can say maintain the integrity of long head of bicep brachii tendon. So with this we are completing the lecture. In our next lecture we will move further toward the biomechanics of glenohumeral ligament, that is the shoulder joint biomechanics. Till then you keep on studying. Thank you to one and all.